Right. So I'm going to be talking about diabetic retinopathy screening, how it started off in the UK, and then what work I have done in Zambia in Africa. So in the UK, if you look at the populations, we've got 4 nations, and this diabetic screening program is separate in these different areas. Each of these nations have got their separate program. So Scotland has a population of 5.2 million, Northern Ireland 1.8 million, Wales has a population of 3 million, and England has a population of over 51 million. And in England, if you look at it, the diabetes is 2.6 million diabetics. So the diabetic eye screening program is actually linked to the NHS in England. So it's the NHS diabetic eye screening program, and this depends on early detection, identification, and appropriate treatment of patients with sight-threatening retinopathy. The 4 UK nations were one of the first countries in the world actually to introduce systematic national screening programs for diabetic retinopathy. The National Service Framework for Diabetes was set up in 2003, and by 2008, we actually had local retinal screening programs covering the whole country. The local programs in England deliver screening in line with the screening program, national service objectives, and they also have quality assurance standards in place. Now, there are various models of screening that are used in the UK, and this vary from screening in static units using cameras in the hospital or in the diabetes center, mobile clinics where they are either in the general practitioner surgeries or in screening vans, or there are some optometry-based practices as well by accredited optometrists. All 4 UK nations use screening and accreditation package for screeners, which is offered in conjunction with City and Guilds, and they award them a level 3 qualification in diabetic retinopathy screening that consists of 9 learning units. As far as quality assurance is concerned, all programs carry out their own internal quality assurance checks by regularly monitoring their screening data, and the programs are also held accountable through external quality assurance processes where you have visits to the different screening programs and submissions of some key performance indicators and annual reports. So for example, we have targets to meet, like if you have identified a patient with proliferative diabetic retinopathy at screening, then you need to get that patient into the eye clinics for laser treatment within 2 weeks. So those are some of the standards that we have to meet, and that's over 95% is the expected standard. So based on the screening program in the UK, we decided to do something in Africa. The Vision 2020 Links program is a program that is run by the London School of Hygiene and Tropical Medicine, where they identify a UK trust or a UK hospital and link them to a hospital in the African country. So we at Frimley were linked with Kitwe Central Hospital, which is in the Copperbelt province in Zambia. So Zambia, as you can see, is a landlocked country. That's there, and it's got 10 provinces. And the Copperbelt province was one of the provinces where we were linked to in Kitwe. If you look at the eye care in Zambia, the facilities are pretty poor. So you have 3 tertiary hospitals, which is the University Hospital in Lusaka, Kitwe Central Hospital, and Livingston Eye Hospital. At secondary level, they have 4 provincial hospitals, and then they have primary care hospitals. We decided to roll out the screening program in the Copperbelt province, and the major towns that we targeted were Ndola, Kitwe, Chingola, Mufulira, and Luinshire. And the aim of the program was to reduce visual mobility caused by diabetic retinopathy by facilitating an early diagnosis and treatment of sight-threatening retinopathy through population screening. The objective was that you would offer annual retinal screening to all the eligible individuals who have diabetes, and the screening would be carried out with a digital photograph, and those identified with potentially sight-threatening disease would have rapid access to treatment, assessment and treatment. Like I said, we decided to focus first on just on the Copper Belt province. Funding has been, as you can imagine, is a big issue in Africa. So what we did was we actually linked in with the private mining hospital in Chingola, which offered to run the screening program for a year before it was then taken up by the Ministry of Health. The other thing was the people were not in Africa were not aware of how diabetes can actually affect the eye and cause blindness. So we had to do a lot of education programs for raising the public and awareness, as well as awareness amongst the physicians that this needs to be done. Then, of course, we had to train the personnel to do the screening and identify the patients. The other problem we faced was that we did not have a single list of all diabetics in the catchment area. So we had to actually go to the pharmacy registers sometimes to actually collate that register of diabetics. We also had to run education programs, and I think running education programs in churches, etc., were actually much more beneficial than trying to write letters. Capacity building, if I tell you that, the number of ophthalmologists in Zambia, they have 10 provinces, they only have 8 ophthalmologists there. The rest are all in training, and so we decided to use unskilled workers to actually do the screening. So these are high school dropouts, and we train them how to take pictures with the camera and also to grade the images. So what happened at screening was, so you can see there's a little banner. That banner was they used to publicize screening, and they were told that this was the time this mobile van is going to be coming here for screening. The patients then come in, they have a registration process where their blood sugar is tested, their blood pressure is tested, and besides taking the history, then they have their vision tested, dilation drops applied, and intraocular pressure tested. Pictures are taken, and then the pictures are then sent to the laptop, graded at the same time, and then the patient is counseled. This needs to happen at the same time, because in Africa, if the patient comes in and you haven't actually told them the results of the screening program, then you may not get them for treatment. So you need to actually counsel them and tell them this is what is there. You need to actually have treatment delivered this way. And if the changes for sight-threatening retinopathy were found, then they were referred to the Kitwe Central Hospital. Otherwise, they were actually invited for screening in a year's time. The patients who were brought into Kitwe Central Hospital then actually had further tests done. So at the Kitwe Central Hospital, they have facilities to have OCT and fluorescein angiography as well. And once that was done, then they were treated appropriately either with laser or with intravitreal Avastin injections, which was available in Zambia, and or if they needed surgery. As you can see, in the first year, we screened 2,689 patients, and the 594 were referred for various forms of treatment. And interestingly, I mean, this was just in the first cohort of patients that we had screened. Now, if you look at the International Diabetes Federation, it estimates that in sub-Saharan Africa, by 2030, you would have 24 million diabetics. And so it was really important to actually get the Ministry of Health on board. So one of the things they had found was as they did the non-communicable disease strategy, the diabetes was highlighted as one of the poorest for diagnostic facilities and access to treatment. So what we did was we actually made sure that when the non-communicable diseases national strategy came out, diabetic retinopathy screening was a part of that. So building on the success of this program, we have now actually expanded it to Zambia, the whole of Zambia, and we run a 3-day educational event at the University Teaching Hospital. We have developed a DRNet toolkit as well as a laser toolkit to help with this. And it's interesting, we do run a practical session on day 2 and 3, which is actually giving them an idea about how to set up a database, how to actually screen, how to grade the images, and how to counsel the patients. What has gone well is that all those people that we trained in Kitwe in the Copper Belt are now actually being the trainers. They are now the trainers for the groups of people that are coming in to be trained, and that's been really good. And the practical application of theory into patient assessment and treatment in a clinical setting was really valued by the people who attended it. The fact that the Ministry of Health has been on board is great, and it's the enthusiasm of the attendees and the people who actually we are training has been really good, because you're actually taking people who don't have a clue about what the eye is, and you're teaching them how to take pictures and how to grade the images. Thank you.